Great. Well, hello, everyone. Good morning, good afternoon, or good evening to you, wherever you are. My name is Oriel Fernandez, and I lead CHAI's hepatitis program based out of Kigali, Rwanda. Apologies, we've had a little bit of a technical issue with our video settings in Zoom that we're trying to navigate. So hopefully some of us who are presenters and panelists will be able to mitigate this issue and come on video shortly. Firstly, I'd just like to thank you all for making the time to join this webinar focused on sharing the highlights from our recently published Hepatitis B Market Intelligence Report. I want to acknowledge upfront, as with many areas of CHAI's work, that we produced this report thanks to contributions of many individuals who engaged with us. First and foremost, our Ministry of Health counterparts in all the countries we support, suppliers, distributors, civil society, WHO, and other organizations. I want to especially thank our government colleagues of Cambodia, Ethiopia, India, Rwanda, Nigeria, and Uganda, who worked so closely with us on a tenofovir scoping exercise, which we highlighted in this report, and we'll hear from some of the country representatives a little later in this webinar. A big thank you to our CHAI team members who helped bring this report to fruition. And finally, I want to acknowledge the UK Government Foreign Commonwealth Development Office, who provide ongoing support to CHAI's hepatitis program. Just a few logistics up front before we jump into the content. Please type in questions using the Q&A function. We have a number of team members monitoring that forum and will respond in real time or save your questions for the discussion session a little later in our webinar. This webinar is also being recorded, and the recording along with the materials will be disseminated a little later this week. I see that the slides have been pulled up, and I might ask the individual controlling the slides to move to the next slide. Great. So just to set the stage for our webinar, we wanted to talk a little bit about, where do we stand on progress on HBV? I'm sure that most of you attending this webinar are aware that hepatitis B remains a major cause of liver disease globally, with significant testing and treatment gaps. Data from the WHO indicates that only 10% of those estimated to be living with hepatitis B have been diagnosed, and far fewer are on treatment. And that a combination of elements like limited awareness, limited funding, and a need for more simplified interventions for testing and treatment are major drivers of this gap. Fortunately, there are new opportunities that are emerging that have the potential to really boost the market and enable more access to testing and treatment. On the policy front, the WHO is in the process of updating the hepatitis B guidelines with an eye towards expanding the treatment criteria and simplifying the continuum of care. And we're so fortunate to have Dr. Philippa Easterbrook as a presenter who'll share a highlight on this guidelines update process a little later. On the financing front, the Global Fund has expanded its hepatitis-related policies with specific guidance for hepatitis testing and treatment services eligible to be included in the 2023-2025 funding round, which many countries are right now preparing applications for. CHAI published a separate toolkit highlighting this opportunity, which is available on our website. And finally, multiple countries like Cambodia, Ethiopia, India, Rwanda, Nigeria, Uganda, and many others are scaling hepatitis B testing and treatment services, really demonstrating models of service delivery and integration into existing health system infrastructure, given several of the tools used for testing and treatment of HBV overlap with those used by other health programs. So, I think the bottom line here is there's just so much opportunity for the HBV market, but we also recognize that we have a long way to go to meet some of our targets. Can I have the next slide, please? Right. So just a bit of background on this report. This report is part of the Market Intelligence series that CHAI routinely publishes to highlight key updates on trends in the hepatitis market. It covers several topics, as you can see from the list featured on the right-hand side of your slide, including an overview of the supplier landscape, volume and pricing trends for diagnostics and treatment, and new areas like the pricing variations between tenofovir procured by HBV and HIV programs, and also combination RDT markets and testing. The report targets a broad range of stakeholders like governments, manufacturers, distributors, donors, and a range of technical assistance organizations working in the hepatitis disease area. And we hope that all stakeholders will be able to use this report to enable better pricing and scale access. Can I have the next slide? Great. So here you have the agenda for the remainder of this webinar. We'll start with some highlights on the HBV treatment market, including experiences from a few countries. We'll then move into highlights on the HBV diagnostics market before hearing some perspectives on the outlook of the market and community access challenges. And hopefully at the end, we'll have some time for Q&A and a discussion. So without further ado, I'd like to pass it over to our first presenter, Navya Sharma, who is a senior analyst on CHAI's global markets team supporting our hepatitis program and is based out of New Delhi, India. Navya will talk through the HBV treatment highlights, and Navya, I'll pass it over to you now.
Thank you so much, Uriel. Hello, everyone. In this segment, I will talk to you about the highlights of the HBV treatment market and a scoping exercise that I undertook for the TDF drug. Later, we will also hear from countries on how they're accessing HBV commodities. Now, I'd like to start the treatment highlights by discussing the recommended treatment for HBV. Here, we can move to the next slide. Now, WHO recommends the use of TDF and entecavir for treatment of HBV infection in all individuals aged 12 years or older for whom antiviral therapy is indicated. Please note we have not covered TAF in this report as it isn't a part of current WHO guidelines. TDF has been a mainstay for HIV treatment and has the same dosage of 300 mg per day, approved for HBV treatment as well. In terms of availability, 6 generics for TDF were WHO pre-qualified at the time of report publication. Entecavir, on the other hand, has 1 generic WHO pre-qualified product in the market. Now, moving to the next slide on volume trends. As part of the report, we analyzed the India export database, which gives us a fair sense of global TDF supply, as Indian generics are major suppliers of TDF to LMICs. In 2021, approximately 3 million packs of TDF singles were exported by Indian generics to LMICs, and this was approximately 150% increase from the previous year. Now, we know that people living with HIV are mostly treated with a fixed dose combination therapy of TDF, and hence we can assume that a majority of the TDF singles that were exported were for HBV treatment. Now, while the export of TDF has increased, WHO estimates that only 2.2% of eligible HBV patients are actually on treatment currently. Now, this leaves anywhere between 29 million to 67 million patients worldwide who are eligible but not on treatment. This demonstrates a significant opportunity to scale up HBV treatment across countries, and this demonstrates an untapped market opportunity, which we estimate to be anywhere between $1 to $2 billion annually. We also estimate that approximately 60% of this market is across LMICs, and this is taking into account the geographical spread of HBV burden. Now, moving to the next slide on pricing trends, which is something I want to kind of briefly take you through. On the screen, you can see a graph that shows price comparisons across 9 countries, and this is a fairly diverse set of data points. In general, we have seen the price of TDF that the price of TDF has been driven down over the past 2 decades due to its wide use in HIV treatment. For instance, the current price of TDF negotiated by the Global Fund is approximately $28.8 ex-works for a year-long course and approximately $31.6 in the country for a course of the same duration. However, while collecting pricing data from countries and interacting with stakeholders, we observed that several of them reported procuring TDF at significantly higher prices, specifically for HBV mono-infection programs. Also, there is significant variability across LMICs, as you can see in the graph. For instance, in India, where the national program procures TDF it only costs about $31 for a year-long treatment, while in Cambodia and Nigeria, where procurement is by hospitals and private pharmacies, a year-long course of TDF costs $360 and $162 respectively. Now, to better understand this rather large price variation, collect relevant pricing data, and evaluate market shaping strategies that could allow hepatitis programs to also procure TDF at a price parity with HIV programs, CHAI undertook a TDF scoping exercise in a set of focus countries. Now, the next slide, I would like to briefly take you through the setup of the TDF scoping exercise. Here we can move to the next slide. Now, out of the 9 countries that you saw on the previous slide in the price graph, we chose 6 focus countries for the purpose of this exercise. Now, these countries include India, Ethiopia, Rwanda, Uganda, Nigeria, and Cambodia. Now, these countries fall in either of the 2 buckets that are on the bottom of the slide. So they either have coordinated public hepatitis B programs and provide free care to the patients, or they have no publicly funded HPV services. That is where patients actually end up paying out of pocket for care. Now, for the purpose of this exercise, we took the price negotiated by Global Fund as the benchmark price. So the price I just spoke to you about, the $31.6 price, was basically the parity price against which we evaluated the other prices. Now, esteemed speakers from the Ministries of Health of Ethiopia, India, and Uganda will take you through their country's national programs and how HPV care has shaped, especially with respect to the procurement of TDF. After the country slides, I will talk to you a little more about the learnings of the exercise and the strategies we recommend for procuring TDF at an affordable price. Back to you, Aurea.
Thanks so much, Navya, for sharing the treatment highlights from our report. Now, I think a key point here is that despite tenofovir being the mainstay for HIV treatment for a number of years, as you can see from the chart that Navya presented, there's still significant variability in pricing between HIV and HBV programs across countries. And we'll now dive into some of the specific country level experiences on this front. So I'd like to introduce Mr. Wengene Adunia and Mr. Melese Georgi from Ethiopia. Mr. Wengene Adunia serves as the Senior HIV Prevention and Control Officer and Hepatitis Focal Person within the Ministry of Health in Ethiopia. In this role, he is responsible for the annual planning and coordination of HIV and hepatitis program implementation, including a range of activities like conducting training sessions and providing site supervision and others. Mr. Melese George serves as the lead for TB, HIV, and malaria quantification and market shaping at the Ethiopian Pharmaceutical Supply Service, and is responsible for monitoring and ensuring supply availability across the supply chain, and advises on a range of strategies and development of tools needed to ensure availability of commodities. Mr. Adunia and Mr. George, thank you so much for joining us, and over to you.
Oriel, I think we can start with India. My apologies for not flagging this. They're just joining in. They had to drop off and join it again. So
Okay.
Dr. Sandhya Kapra, ma'am, are you able to unmute and get on video? Hello, ma'am. You may move to the India slide, which is the next one.
Great. So we'll come back to Ethiopia in just a bit once we have our presenters back online. While we're pulling up Dr. Kabra's slides, let me first of all welcome and say thank you to Dr. Sandhya Kabra for joining us. Dr. Kabra needs no introduction in our community. She currently holds the portfolio of Deputy Commissioner of the National Viral Hepatitis Control Program and Additional Director of the National Center for Disease Control in India postings. She's also contributed significantly towards India's COVID response by engaging, establishing, and expanding services for testing in the country. Dr. Kabra has more than 25 years of experience in diagnostic services and a range of experience in program planning, policy, and implementation at the national level. Dr. Kabra, thanks again for joining, and over to you.
Thank you so much. Thank you for having us to present our case study. And initially, I would like to say that India is one of the largest public health programs that offers hepatitis B care to patients who require it. And this is a centrally coordinated, domestically funded program by the name of the National Viral Hepatitis Control Program. India as far as the burden is concerned, we haven't really had a national estimate of the burden, but we have a seroprevalence of around 0.95% in the country. We launched the program in 2018 with services free of cost, both diagnostic and treatment for hepatitis C, which we expanded in 2019 February to include treatment and management for hepatitis B. The program scale at this point in time is around 868 facilities across the country offer treatment for hepatitis B and C along with diagnostic services. And we are continuously in a process of scale up in spite of COVID and being a very young program. I think we have managed to scale up in a country as large as ourselves in a very short duration of time. So really, what is the unique thing in India's program? We chose to follow the health systems approach, and we coordinate very efficiently with the already existing programs to be able to not replicate and reinvent anything and utilize by integration with the National AIDS Control Program, already a very old program in India, with the reproductive and child health program, where we talk about universal screening amongst pregnant women, and we offer intervention to the babies born. After screening of these women, we refer them for institutional deliveries, and they are labeled as high-risk pregnancies, and all free services under the RCH are offered to these women. And the baby born to a positive woman is receiving the hepatitis B 0 dose and the hepatitis B immunoglobulin. We coordinate very closely with the immunization division. The immunization division provides the hepatitis B vaccine, which is the hallmark for prevention, both to the baby, that is the 0 dose, and the immunization division is also assisting us in providing this vaccination for the healthcare workers. We also coordinate with the existing surveillance programs in the country, the HIV Sentinel Surveillance, the Population-Based National Family Health Survey, and with blood safety, where already screening for hepatitis B and C is happening. In the program overview, we cover the entire population, so it's not in a focused area, it's entirely over the country. All the states and union territories are covered. We have active outreach to vulnerable groups, including pregnant women, incarcerated population, PIVTs, PLHIVs, and other HRGs. The services that we cover are both diagnostic and management services, along with preventive services, which include HBIG and vaccination, and also IEC. And the most important thing here is that we are a domestically funded program, and all services, both diagnostic and treatment, are offered free of cost to the patient. The National Viral Hepatitis Control Program approximately allocates 12 million for treatment and diagnostic commodities. This is the amount that is in the last year we spent. So it's an annual amount of about 12 million USD. Next slide, please. So India is one of the countries where the TDF scoping exercise has been assessed. And I believe that there is a price parity with the benchmark price that has been found. And in the diagnostic trends, really, the diagnostic commodities are procured in a decentralized fashion, and we are a federal structure. So at the state level, the diagnostic kits are both for screening as well as for viral load are procured at the state level. The program has been able to procure the hepatitis B surface antigen RDT for as low as 0.09 USD and the hepatitis B virus viral load for approximately $15. India has screened over 14 million individuals for hepatitis B in the last year using the RDT. The key findings from the TDF scoping: the procurement at price parity. India has procured in the last procurement nearly 20,000 patient courses of TDF for approximately 2.6 USD per month in 2021. India uses pooled procurement, which means we centralize the procurement and we are in a position to use some of our existing systems for logistics and supply chain management, and we provide the drugs in kind rather than cash to the states. we have also explored competitive tendering, and through open tendering, India has also encouraged a large supplier base to be able to compete so that we can get good pricing. And in the last tender, if we were to evaluate, we had about 15 suppliers who took part in the TDF tender. And we feel that use of competitive tendering and pooled procurement has enabled effective market shaping as far as India is concerned. Thank you very much.
Thank you so much, Dr. Kabra, for sharing India's experience. I think it's just really inspiring to see the government of India's leadership on hepatitis offering services free of cost to patients, and just really valuable to learn how open tendering has enabled a large supplier base, and centralized procurement has enabled India to access pricing of HPV drugs at parity with the HIV program. So I think a lot to learn from India's experience there. We were just speaking that I think we're still waiting on our stakeholders from the Ethiopian government to connect. In the meantime, Asmama Salesh, who's the manager for the HIV program, supporting viral hepatitis efforts in Ethiopia as part of the CHAI team, has offered to come and share just a summary of Ethiopia's experiences and highlights. Asmama has worked with CHAI for 7 years. Asmama, thank you for stepping in last minute, and hoping we'll be able to have Mr. Wegene and Mr. Malese join us shortly.
Thank you, Aurel, and hello, everyone. Yeah, like you said, the presenters from the Ministry of Health and the Ethiopian Pharmaceutical Supply Service has the connection issues. So I will try to cover the slides. I just communicated them that I'm going to cover the slides, and they will try to join in the meantime, and we'll try to address questions if there are any specific to the Ethiopian context. So coming to the presentation, let's start with how viral hepatitis B is a huge issue in the country, because the prevalence, the pooled prevalence in the country is around 9.4%, and this is estimated in a number of people to be 11 million. So this is very huge burden in the country. And considering the burden, the government, specifically the Ministry of Health, has given due attention to this health burden. And considering that the ministry is trying its best, for example, by making policies and guidelines in place, there are strategic plans prepared and under implementation. And currently, the service is made available, the screening service is made available at all health facilities, more specifically public health facilities. There are a number of health facilities in the country, in thousands of health centers and hundreds of hospitals. So all these health facilities are supposed to provide hepatitis B screening tests. Beyond that, the country is scaling up the treatment centers from 13 to 90 in the previous year. And also, regardless of the service is getting expanded or scaled to this level, but the expense is still out of pocket for most of the services, except the hepatitis B surface antigen tests for pregnant women. Let's come to the program objective. The government is allocating close to $1 million to procure hepatitis B commodities. So these commodities are now available in the country for use at the specified health facilities, public health facilities. And the government is currently implementing the second 5-year strategic plan, which is spanning from 2021 to 2025. The first strategic plan was implemented between 2016 and 2020. So this is now the time of implementation of the second strategic plan of the country. And also the country has developed a national strategic plan for triple elimination vertical transmission of hepatitis B from mothers to their infants. And Ethiopia is also committed to prevent transmission by providing access to safe and affordable care for people. Next slide. Next slide. All right, yeah. Coming to the diagnostics part a bit more wider, the country has procured 1 year of procurement actually. Procured RDTs, which is hepatitis B surface antigen RDTs, value of 1.85 to 2.75 USD per test, and totally 343 hospitals and 3,587 health centers, public health facilities in the country are providing this testing service. So the test, the hepatitis B surface antigen test, is provided free of cost for pregnant women. For other clients, it is covered out of pocket. The government agency, which is named Ethiopian Pharmaceutical Service Supply Services, abbreviated as EPSS, is responsible to procure and distribute health commodities. So it procured around 3.7 million test kits in 1 year time, and the major suppliers are 3 so far to source these test kits. The major procurement mechanism is RDF, which is revolving drug fund. So the budget initially allocated by the government for the EPSS is being revolved and used to procure drugs, and that quantities of drugs procured are distributed to hospitals with certain margin, and that is again revolved to procure other products. So this is applied for all types of products actually. It's not only for viral hepatitis B, and it is found very helpful to improve accessibility of essential commodities. This is the mechanism now being used to procure and make available hepatitis B commodities. The mechanism of procurement is usually competitive bidding. International competitive bidding is utilized by EPSS, and different international suppliers compete openly. So it is very helpful, to find the products with a cheaper, I can say, cheaper price. And the cheaper cost is achieved by collecting the demands from different parts of the country and all the types of public health facilities, so that demand is aggregated and comes to the center, and that aggregated quantity is floated or tendered by EPSS. So that is how international suppliers are competing, and then finally it was possible to achieve a cheaper price, for example, for the procurement of TDF. So hospitals, when they receive the products such as TDF from EPSS, they pay the price with some margin added on to from EPSS, and then it is believed it is affordable to the clients, although the accessibility is yet to be improved because limited hospitals are making the product available for the clients. So as best practice, I think before concluding and stopping, the alternative financing mechanism the country has is the revolving drug fund, and it is very helpful to procure TDF with affordable or cheaper price. Let me stop here and thank you for listening. And if there are any questions, I think we can add more based on the questions to be raised. Thank you. Over back to you, Aurel.
Thank you so much, Asmama, for sharing Ethiopia's experience on behalf of the Ministry of Health and jumping in so last minute. You know, I think it's just really interesting to learn of Ethiopia's strategy to pool demand and leverage volumes at the central level using a revolving drug fund. And, you know, I think the take home message for me here is for countries who are just starting up HBV programming and may not have a centrally funded program, there's still an opportunity to access better HBV pricing, leveraging alternative financing mechanisms like revolving drug funds, which have enabled the affordability and accessibility of TDF in countries like Ethiopia. So really interesting. I see a couple of questions coming into the Q&A chat. Just a reminder for the audience to please put in your questions, and if it's a question on a specific country, please indicate which country your question relates to. We were supposed to move on to a presentation from the Ugandan Ministry of Health, but unfortunately, the representative is having some connection issues. So we're going to skip over and come back to that presentation when that representative has joined. For now, I'm going to pass it over to Navia again. Navia, perhaps maybe you could help just summarize some brief reflections from the TDF scoping exercise. What are some of the take-home messages now that we've heard some of the specifics from each of the countries? Back to you.
Great. Thank you so much, Oriel. And now, of course, I'd like to take the listeners to through some of the key takeaways from the TDF scoping exercise. So now, across the 6 focus countries that we analyzed as a part of the exercise, TDF emerged as the preferred treatment for chronic HBV. We also found that public programs and hospitals use a variety of different mechanisms to actually procure the drug. We learned that a centrally financed program responsible for procurement or other appropriate mechanisms to facilitate pooled procurement across health facilities could enable countries to procure TDF at an affordable price. We also observed that HIV programs mostly procured fixed dose combination HIV treatment products, which include 300 mg TDF and other antiretrovirals. These fixed dose therapies, including small volumes of TDF singles, are often procured through international procurement mechanisms like Global Fund and PEPFAR. In Nigeria and Cambodia, the 2 countries with the highest TDF prices out of all the focus countries we analyzed, there is no publicly funded HPV program, and hospitals still grapple with high TDF prices. And this is primarily due to 2 reasons. Now, firstly, there is a lot of fragmented demand. And that kind of leads into the second issue, that is that a fragmented demand leads to often low order quantities, which do not allow for a price negotiation or do not allow for that price to be driven down. We also understood that procurement mechanisms that utilize a volume-based pricing via pooled procurement and competitive bidding can actually optimize for prices very well. And we saw this in the case of India, Uganda, Rwanda, and Ethiopia. Lastly, alternative financing mechanisms such as revolving drug funds that Asmama just touched upon also emerged as potential methods to combat high out-of-pocket expenses in countries, specifically with no publicly funded HPV care. Now, from these learnings emerged some strategies which are on the next slide. And I'd like to take you through the 4 broad strategies that we recommend to access TDF at an affordable price. Here we can move to the next slide. Now, we found that aggregating demand to leverage volume-based pricing was incredibly effective. Countries like Uganda and Ethiopia have been able to pool demand to access TDF at fairly reasonable prices. In terms of the most effective purchasing option, while there exist many, from open tenders to competitive negotiations to a direct purchase, and all of these have fairly different costs and complexities attached to them, we learned that open tenders usually yielded significant benefits as they foster an environment that is favorable to lowering prices. India procured TDF through this process and saw incredibly wide supply participation, something Dr. Sandhya Kapra spoke to. So India saw over 15 suppliers participate in the tender, and it was actually able to drive down its prices to parity. Now, another effective strategy is to use pricing negotiated by international procurement mechanisms such as global fund pricing as a benchmark while procuring. Uganda's procurement agency does this very well and regularly uses global fund negotiated ARV pricing to inform its negotiations for tenders through the government budget. Lastly, we observed that alternative financing mechanisms such as revolving drug funds yielded great results, especially for programs where patients pay out of pocket. Ethiopia, as Asmama again spoke to, leverages such a mechanism and does it incredibly well, where it pools volumes from across the country, leverages this pool demand, and accesses fairly affordable prices for TDF. Now, as I conclude this section, I'd like to leave you with a thought. A lot of the strategies that we've discussed might seem fairly simple, and in some cases, even obvious. We found that in most countries, these simple fundamental interventions were needed to access TDF at an affordable rate. We observed that markets in most countries were ripe for picking, and just simple, well-implemented strategies like the ones we just discussed can help countries access TDF at an affordable price and improve treatment access immensely. With that, I conclude this section.
Thanks so much, Navya, for summarizing the reflections from the scoping exercise. Really important remarks right at the end. I think for me, two additional key highlights stand out. Firstly, while we do see pricing differentials across countries, a lot of what's driving the pricing variation is quite context specific. And I think this speaks to the need for more assessments done across a broader range of countries of where the pricing stands, what the barriers are, and maybe what are some of the solutions for the countries who are accessing at parity, what are they doing, and what can we learn from them. I think secondly, of the 6 countries we conducted the scoping work in, 3 still have emerging HPV programs, which are not centrally funded. But, as I mentioned before, Ethiopia's experience shows that even in these countries, by leveraging certain procurement and financing mechanisms, aggregating demand, pooling procurement, things that, seem simple, can get you closer to pricing parity. But we'll talk a little later, perhaps in the Q&A and in the discussion, about what some of these mechanisms are, how they're being facilitated, and considerations for them as well. So, we've spent a little bit of time on the HPV treatment market highlights. We're now going to shift from a treatment focus to a diagnostics focus, and I'll hand it over to Robia Islam, who's an associate on CHAI's global diagnostics team, supporting our hepatitis program, and is based in New York, USA. And Robia, over to you on the diagnostics highlights.
Thank you, Oriel. Hi, everyone. I'll just be taking you through key market highlights of HPV diagnostics from the report. To provide a brief bit of background, the report covers market trends across recommended HPV diagnostic tests found within WHO guidance, beginning with the use of hepatitis B surface antigen test, which can be done as either a rapid diagnostic test or as a lab-based immunoassay. A positive HB surface antigen test is then followed by an HBV viral load test to confirm for viremic infection, while also assessing for stage of liver disease. Alternatively, in cases where viral load is inaccessible, another alternative is the use of HBe antigen, and this is recommended for use when testing pregnant women only. Next slide, please. So firstly, just understanding some of the trends across the hepatitis B surface antigen products. On the supply side, there are 4 HB surface antigen products which have retained WHO pre-qualification, including 2 rapid diagnostic tests and 2 lab-based immunoassays. Beyond the WHO pre-qualified products, there are several other quality-assured HB surface antigen products which have been approved through other regulatory bodies, attaining approval such as CE mark or FDA approval. These products are also approved for procurement from major global funders such as the Global Fund. Generally, RDTs can be the preferred option, providing results in 30 minutes or less and often require less infrastructure and training. In terms of pricing, global prices for HB surface antigen RDTs are generally comparable with those of RDTs RDTs across other disease areas. As you'll see here in the graph, of the multiple hybrid and LMICs that were surveyed, most are procuring the test at around the $1 price point. And prices can typically range from 58 cents to $1.22, with exceptions like India, which run at 10 cents on the low end, and Nigeria up to $2.40 US dollars. In instances where countries are procuring more than one HB surface antigen product, pricing ranges have been reported, representing both the low end to the high end in country pricing. Next slide, please. On the supply side for HBV viral load, there are multiple manufacturers who now offer HBV viral load products, many of them which have notable regulatory approvals, including options for point of care testing. As a recent update, the WHO has extended the pre-qualification process to include HBV viral load, inviting manufacturers to submit applications. The process generally takes up to a year from the time of application. However, this presents an opportunity to prioritize quality, accessible HBV viral load products and facilitate expansion into high burden settings. Taking a closer look at volumes, we requested data across major HBV viral load suppliers and demonstrated a 70% increase in procurement volumes from 2016 to 2019. This is, just as a caveat, non-exhaustive data from the participating suppliers, but shows at least 400,000 tests being procured in 2021, which is below the expected need. A growth declined in 2020 due to the COVID pandemic, but sale volumes are forecasted to increase going forward. Most sales have been attributed to two regions, Asia Pacific, the Europe, Middle East, and Africa, with smaller sales in recent years from Latin America. In terms of pricing, most major suppliers offer global access pricing for LMICs ranging from $9 to $15 US, with variable terms, conditions, and country inclusion. As such, a final cost paid by countries often varies. So just demonstrated here, you can see on the low end pricing ranging from around $9 to the high end 62 in Indonesia. And then just also as a note that the pricing in Vietnam reflects prices covered by the National Health Insurance Scheme, and 80% of that is covered through the policy and the remaining is out of pocket. Next slide, please. Just in terms of the HBe antigen, the alternative method of testing for pregnant women, there are products in the market, several of which have SRA approvals. However, there is no WHO pre-qualification process for HBe antigen. In terms of pricing, they're generally more affordable than HBV viral load, with prices for RDTs ranging from 30 cents to $4.50, and prices for lab-based assays, which can range from $2 on the low end to $40 on the high end. Some of the factors for limited uptake are due to one, variable test performance, varying test performance across settings, with demonstrating varied sensitivity and specificity for the test overall. And you can see in the report, we've demonstrated several studies which highlight this. And then beyond this, just generally limited implementation knowledge with other countries. I think these both point to a larger need for countries to consider validating HBe antigen testing in settings considering use, and to share lessons learned across settings. Next slide, please. Lastly, as countries continue to prioritize triple elimination as a public health priority, there are increasing opportunities to provide comprehensive integrated approach across antenatal care settings, beginning with diagnosis. So the report goes over a non-exhaustive list of combination RDTs that are available, demonstrating 4 products. There are limited options with SRA approvals. Of the ones mentioned, one product is CE marked and another is pending approvals. At the moment, there is no PQ process for triple combination RDTs. Of the products that are mentioned, prices can range from $1.45 to $2 US, which is comparable to the cost of several single disease RDTs. Studies have demonstrated the feasibility of integrating HBV screening into already existing vertical transmission programs within ANC settings, which marks an opportunity to continue operational research to demonstrate usability and adaptability of the approach. Furthermore, the experiences of the dual HIV CIF RDT serve as a blueprint for suppliers to develop similar products, which also include a test option for HBV. So just considering some of the factors that we would need to consider to enable market entry, thinking about enabling policy, ensuring that countries are equipped with the strategic plans and operational guidance needed to integrate programming for triple elimination, an optimal product, identifying an optimal combination test characteristics through disease, design, price, so that prices are high quality, usable, and accessible to countries. Thinking on financing and resource mobilization, so ensuring that there's commitments from a variety of stakeholders, including ministries of health and finance and donors alike, to support vertical transmission programs, and identifying a way to sustainably implement, so establishing clearly defined service delivery model to integrate screening services. With that, I will end this portion and hand over back to Oriel. Thank you.
Rabia, thanks so much for sharing the diagnostic markets highlights. I think clearly, over the last few years, we've seen a big increase in access on hepatitis B viral load products, and really welcome the move to have the WHO PQ process extended for viral load products. But still a lot of questions on market uptake and use for hepatitis B E antigen testing and the outlook and potential for more combination testing. And so really looking forward to Philippa speaking to some of these components in a little bit. But moving on to our next speaker, we have Kenneth Kabagambe, and I just want to make sure, Kenneth, you're with us and can hear me before I introduce you.
Yeah, sure. I can hear you. Thank you.
Great. Thank you so much for joining us. Kenneth will be speaking to some of the broader community access challenges to hepatitis B testing and treatment in Uganda, but also more broadly in the Africa region. Kenneth also does not need an introduction in our community. He is the founding executive director of the National Organization for People Living with Hepatitis B, which is one of the only patient-driven NGOs advocating for the rights of hepatitis B patients in Uganda. He's also a member of several hepatitis working groups and committees, and serves as the board director for the Hepatitis Fund, and has extensive patient experience in viral hepatitis, and spent a lot of time advocating for patients' rights and accessing quality diagnosis, care, and treatment. Kenneth, I'll pass it over to you for your perspectives now.
Thank you so much, Oriel, for the kind introduction. First of all, I want to thank you for giving me the opportunity to provide the community insight in this discussion. So Uganda has a prevalence of 4% of chronic hepatitis B, which actually translates to about 1.8 million people who are chronically affected with hepatitis B. Unfortunately, majority of these people do not actually know that they have the infection, and most of them get to know when it is very late in the advanced stage of liver disease. We have also data from the Uganda Cancer Institute that points to about 80% of the liver cancer cases registered at the Uganda Cancer Institute resulting from hepatitis B. And this actually brings a lot of public health issue and calls for urgent and immediate actions in regard to increasing the levels of awareness, which still are very low in the country, and ensuring that diagnostics are actually extended to the community facilities. Apparently, we do not have a clear referral system for hepatitis B patients, especially for those who test positive in their communities. They do not know where next they are supposed to be going. And most of the tests, especially which help the doctors to identify whether the patients are going to be initiated on treatment or not, are still not, downscaled in the lower health facilities. Even at district level, some of the tests are not readily available, like the liver function test, the hepatitis B antigen, And the viral load is actually being provided free of charge, but the turnaround time also still remains a challenge, and most of the patients end up giving up on the results of the viral load. So these are some of the issues that patients and the communities in Uganda are currently facing. There is also another major challenge in the management of pediatrics, especially those who test positive for hepatitis B and they are eligible for treatment. Apparently, the country does not provide entecavir, which is the option treatment mode for these categories of children. And it is still a very big challenge at the moment. We also look at the issues to do with the co-infections of HIV, hepatitis B. Most of the people actually who are co-infected with the hepatitis B and HIV sometimes do not know that they have the co-infections. And that's why we are calling upon all government agencies, even donors, to integrate the hepatitis B into the existing HIV programs, because we feel that integration would actually help in leveraging on the existing structures. This is possible. There are studies that have actually been done to show acceptability of such kind of service delivery. The other challenge is actually for the maternal child health program is in the country. Majority of the mothers who have actually been tested for hepatitis B disease and they have been identified as positive still have a challenge of linking them to care, because most of the hepatitis B clinics in Uganda are still working on not on a daily basis, but they choose one day in a week. So if a pregnant mother came to the hospital today, maybe for the antenatal services, and they are told they have the hepatitis B virus, they need to come the next day for their appointment. And majority of these mothers either have come from very far, they are fatigued because of the long queues they find at the health facilities, so they end up giving up. So these are some of the challenges that we think are actually crippling the progress to elimination that countries in Africa, governments need to take up and ensure that they actually design public health approaches that are appropriate for them to be addressed. But moving forward, there are opportunities that actually are moving in. Uganda is one of the countries that provides domestic funding. Apparently, each year, Uganda allocates $3 million towards the hepatitis program. Unfortunately, most of this funding goes to the procurement of test kits and vaccines. So literally, little has actually been done to invest in the community awareness and sensitization, which is actually very key to creating a demand of some of these services. And that's why we are seeing most of the test kits for hepatitis B that have actually been procured and some donated by PEPFAR for the pregnant mothers expiring on the shelves of health facilities, because the demand in the community is very low. The awareness levels are very low. So we think in order for us to have value for money for the test kits and the funds that are being invested in the hepatitis B program, there needs to be investment in the community awareness component. PEPFAR has actually played a very critical role in the program for hepatitis B in Uganda, allocating $1.8 million towards the procurement of test kits for pregnant mothers who actually access some of these services during antenatal care. But again, the issue is about the uptake. The uptake is still very low, simply because of the awareness levels. The stigma and discrimination is very key, and I want to applaud the work of the Hepatitis B Foundation, our partners that are trying to document the global, challenges hepatitis B patients face with stigma and discrimination. Some of the patients who have been diagnosed with hepatitis B have actually been terminated from their work of employment, and others have actually been denied travel opportunities to go and work in the Arab countries. You may well know that most of the Ugandan population is made up of the youth, and because of the high rates of unemployment, most of the youth have actually thought to go to Arab countries to seek for employment. But because of the tests that come out positive, they have not been able to get these opportunities, and they end up in depression. The other challenge is actually about also the criteria for the treatment. majority of the people, of the patients actually do not qualify for the current, guidelines. And most of these have actually fell into the hands of the herbalists, because the herbalists seem to be communicating better than the public health officers and the ministries of health, and also the communities they live in. They convince them that they have a cure for hepatitis B, and because people have not been initiated on treatment, they end up falling for these initiatives of the herbalists. And at the end of the day, we have seen so many complications come out of these herbal medicines by advancing their liver diseases. So there are so many opportunities. I think there needs to be a lot of meaningful engagement with the communities, because there cannot be anything for the community if you're not meaningfully involving them. I thank you so much.
Thank you so much for sharing those really important perspectives. I think it's a really important reminder for us all that the work we're doing to increase market intel and navigating market barriers is really ultimately rooted in ensuring that patients, the community, have access to high quality testing and treatment. And you spoke to a number of challenges and barriers beyond the market barriers that we have to address: levels of community awareness, decentralizing testing to the communities, developing strong referral systems, logistic challenges of where health facilities are located at the timings they're operating, stigma and discrimination. Clearly, there's a lot of work to be done beyond just navigating market barriers and increasing financing to ensure this access. And really important message at the end that we have to engage communities and ensure that the community is at the center of the work and the solutions we're designing. Thank you again. I've just been informed that our Ministry of Health representative from Uganda has now joined us, Ms. Viola Kasone. Viola, are you with us? Can you hear me?
Yes, I can hear you.
Great. Well, thank you so much for joining us, and I'm sorry for your connectivity issues earlier on. Ms. Kasone is a laboratory scientist working with the Ugandan National Health Laboratory Services of the Ministry of Health, with experience in infectious disease management and lab surveillance. She coordinates the national testing program for viral hepatitis and advanced HIV diseases in Uganda. And she's worked with the hepatitis program for over 10 years, where she's taken the lead in development of the national hepatitis lab testing guidelines, including testing for pregnant women for prevention of mother-to-child transmission of hepatitis B as part of a triple elimination agenda. And we know that Uganda is really one of the countries at the forefront of that agenda. So really excited to hear from you, and over to you now.
Thank you so much, Fernandez. Good morning, good afternoon, good evening, everyone on the call. Viola Kasone is my name. I think Fernandez has introduced me very well. I work with the Ministry of Health, Uganda, and I'm happy to be here. Sorry, I had challenges joining, but I'm grateful that I've been able to join finally. So I'm going to give you the perspective from Uganda, and I'm glad Kenneth has just spoken. So most of the issues he has really highlighted them. But I will mention that the government of Uganda in 2015 declared hepatitis B as a disease of public health interest. And since then, we have been able to launch a national testing program that was targeting adolescents and adults that were born after the year 2004. So we have been working closely with our health facilities and our development partners, and of course the government of Uganda, to ensure that we conduct testing in the population that was eligible then. So over the years, we have been implementing this program, and we've been able to test about over 5 million people, which gives us about 35% of our eligible population. And we have been able to identify about 4.1% positivity in our population over the years, of which we see that the main if you get into the deep dive of this you find that men are ranking at about 5 points. So our focus has been identify those that need the testing and those that need the treatment. So in terms of screening and parallel testing, we've been able to establish diagnostic capacity with widespread provision of the rapid diagnostic test kits. And we've been able to ensure that testing is happening in over 52% of our facilities. And relying on the national sample transport system, we've been able to identify all the positive individuals, get their samples, and then we link them to the Central Public Health Laboratory where the testing is still conventionally done. So we still see, and of course, we have over 300 experts and over 250 MPMA platforms where we can have the viral load for hepatitis be scaled. And we think that moving into this, and as we write the Global Fund currently, we are looking at putting the hepatitis B test on the GeneXpert platform such that we can improve on the turnaround time and have our results really get to the patients in the fastest time possible. In terms of funding, Uganda allocated, the government of Uganda allocated 3 million USDs towards hepatitis B control activities. And this is the funds we've been relying on heavily to run the activities and also procure the test kits and the medicines and then the vaccines. However, we also have support from our partners. We have support from PEPFAR and Global Fund, and Global Fund is mainly supporting us on the DNA and then PEPFAR supporting us on the test kits. In line with the elimination agenda, we have also embraced this very well, and starting 2022, our focus has been having testing in the ANC clinics. And as I speak now, our performance in the ANC clinics has really improved. We started from about 16% coverage hepatitis B, but over the years we are at least getting to 40%. And so we think that coming quarters, in the coming years, we are going to get to reach at least 90% for hepatitis B. So we still have a challenge of the test kits. We do not have a kit that can do the 3-in-1 test, but we have the HIV syphilis duo and single hepatitis B kit. However, we still want to discuss with the different manufacturers of these kits to ensure that we can come up with a kit that can have HIV syphilis and hepatitis in one, such that the testing can be done as in a one-stop model. Next slide. Next slide, please. Yes, in terms of treatment, I've informed you that our main focus has been linkage to care. And over the years, we've identified about 450,000 patients that will require treatment. And of course, like Ned highlighted, our main challenge has been having these patients and linking them fully well, being that most of the treatment has been localized at regional centers. So we have recently decentralized the treatment to cover beyond the regional referral centers, and we are still struggling to see that all this is integrated into the ART clinics where the hepatitis patients are treated. I should mention that the treatment for hepatitis is freely given, and the GOU covers this fully, where we have TDF procured from the national medical stores at about 4.5 USDs. And of course, this cost is moderately high compared to the HIV. We want to, of course, look at this and see how best we can have better pricing for the hepatitis program. So when you look at our case for Uganda, the supplier for this medicine is a local we can promote by Uganda Uganda Build Uganda policies. So we have been relying on CIPA to provide TDF for our patients, and we are ensuring that at least we want to negotiate better prices and such that we can access TDF at a much more cheaper cost. At least $2 would be a little bit fair to the program. But as I conclude, our main focus here is to see that this TDF gets into the facilities lower than the regional centers, and we are trying to work as MOH and our implementing partners to see that hepatitis treatment is made simple and available to all the patients that require it. Thank you so much, and over to you, Fernandez.
Thank you, Ms. Kasone, for sharing Uganda's experience. Really interesting to see how Uganda has leveraged both existing market intel, namely the Global Fund reference pricing for ARV, along with strategies like competitive bidding processes to access better pricing. And wonderful to hear that the benchmark target pricing is still lower than what you're accessing, and you're continuing to think about strategies to reach that benchmark pricing. Thanks again. I think we're looking at our time and we're running a little bit behind. So I'm going to quickly move us over to our last presenter, Dr. Philippa Easterbrook, who similarly to Kenneth needs no introduction. Philippa has worked with the WHO Global HIV, Hepatitis, and STI program for a number of years and has been championing a number of guidelines development processes, including the current HPV guidelines development update. Philippa, I'll pass it over to you to talk through that process and other perspectives you have on the outlook for the HPV market.
Thanks so much, Oriel, and apologies, you just have my voice. I'm afraid we didn't manage to resolve the video problems experienced earlier. And it's amazing, after 3 years of virtual meetings, the technology always finds clever ways to thwart us. Well, first, to really congratulate CHAI for this very useful, well-executed and practical report to support expansion of hepatitis B testing and treatment. And for the Global Hepatitis Program at WHO, 2023 is the year for hepatitis B, in particular for update of this guideline. And this report will be a valuable complementary tool. Next slide. And next slide. So in the short presentation, I'm just going to highlight the simplification process we undertook with the updated WHO hepatitis C guidelines last year and the planned approach with the Hep B guidelines and some of the opportunities and challenges. So next slide. This slide highlights the global and regional data from 2019, the progress report, which demonstrates the progress on testing and treatment targets, the targets being 90% of those infected diagnosed and 80% of those diagnosed and eligible for treatment. And with the data on the left for hepatitis C and on the right for hepatitis B. And these are the service delivery coverage targets needed to achieve the impact targets of incident reduction and mortality towards elimination of viral hepatitis B and C as a public health threat. We can see that for hepatitis C, focusing on the inside the red box, the global coverage was 21% of those infected diagnosed and 13% overall treated. But for hepatitis B, moving to the right box, only 10% and 2%. And this was uniformly poor across all regions, but particularly in sub-Saharan Africa, the most affected region, at only 2% diagnosed and overall 0.1% treatment. So there is a major testing and treatment gap that needs to be addressed, and expansion and simplification of criteria for treatment and service delivery is key. Next slide. This slide summarizes the progressive evolution and simplification process over the last 8 years in the WHO hepatitis C guidelines that took place over a much longer period with the HIV guidelines, and showing the most recent 2022 update and the 3 products. That's the full guidelines and the 2 policy briefs. So that was the adoption of Treat All in 2018, the adoption of pan-genotypic regimens, the rationalization to 3 preferred regimens in 2018, dispensing with the need for genotyping, the recommendation for treatment of all adolescents and adults and adolescents for treatment in 2018, and now in 2022 down to children aged 3 years or more, with the same 3 regimens that include pediatric dosing and formulations, and then the adoption of formal evidence-based recommendations for decentralization, integration, and task shifting, and the 3 diagnostic innovations to simplify uptake of testing and treatment. That's self-testing, use of point-of-care NAT assays, and reflex viral load. Next slide. And very importantly, these approaches, and in particular, the simplified service delivery and move of services out of hospitals to the more decentralized facilities, such as harm reduction sites, primary care, or ART clinics that are nearer and more convenient for patients, were strongly supported by the community. So based on a comprehensive survey led by partners, the clear message they wanted their initial antibody and their confirmatory viral load test done on the same day and at the same site, and also to be able to start treatment on the same day and at the same site. Next slide. So moving now to the hepatitis B guidelines. So the guidelines were done in 2015. The testing recommendations for both B and C were done in 2017. And there was also an updated guidance on the use of antivirals for prevention of mother-to-child transmission in 2020. And the algorithm is shown on the left, and the key recommendations across the continuum of care shown in the box on the right. And highlighted in red are some of the areas particularly for updating. So just to run through very quickly this comprehensive sort of continuum of care set of recommendations, the recommendation for the use of non-invasive tests for staging for the presence of cirrhosis in terms of who to treat, prioritizing those with cirrhosis based on an APRI score or on clinical criteria, and in the absence of cirrhosis based on a Hep B DNA above 20,000 and persistently abnormal ALT. First-line treatment being those drugs with a high barrier to resistance, the tenofovir, the entecavir, with annual monitoring of the ALT and Hep B DNA, and 6-monthly monitoring for hepatocellular carcinoma with an ultrasound and an AFP. And then the 2020 recommendation for the use of antiviral prophylaxis was in those pregnant mothers with a Hep B DNA greater than 200,000 from the 3rd trimester or e antigen positive. And on the left, showing the algorithm, were the key criteria for who to treat, who not to treat, and the monitoring of those not yet on treatment over time to determine who would be eligible. And this indicates also the monitoring for disease progression, the monitoring for treatment response, the monitoring for toxicity, and the screening for HCC. Next slide. So why the need for expanded treatment criteria and simplified guidance? Well, I think it was shown on the earlier slide, still very low testing and treatment coverage globally. There is a perception that the guidance is complex. It currently needs age, DNA, and ALT to determine eligibility. Other professional societies have already lowered the Hep B DNA threshold for eligibility to 2,000. And the APRI threshold for diagnosing cirrhosis, those who are a priority for treatment of the threshold being greater than 2 was missing cases of cirrhosis. It was insufficiently sensitive. And the existing guidelines at the time they were done really lacked any data from sub-Saharan Africa, which is such an important region, and recognizing some distinct regional differences with a lower antigen positivity and high rates of HCC. The increasing evidence demonstrating genetic integration of Hep B during infection and the oncogenic potential of hepatitis B. And even in those not fulfilling the current eligibility criteria for treatment, the recognition of ongoing horizontal and vertical transmission, the very exciting hepatitis B cure agenda that is really setting the direction of travel for expanded treatment, and the recognition of the lack of simplified care models in contrast to many of those that have evolved now for hepatitis C, with one-stop shops and a test and treat approach. We lack that clear, simplified models for hepatitis B. Next slide. So what do we mean by simplify? And I think it's very important in the response to the call for simplified guidelines to be very clear what we mean by simplification. And if we're to achieve substantial impact on uptake of hepatitis B testing and treatment, we need to address all the steps in the cascade of hepatitis B testing, care and treatment and monitoring. And that includes the serologic testing, the viral load testing to determine eligibility for treatment, linkage to care, treatment initiation, and the lifelong monitoring and adherence support. So what we mean is both simplified criteria for simplified testing and diagnostics, simplified treatment, expanded treatment criteria, simplified service delivery, and simplified presentation of the information with clear algorithms and tools. Next slide. So this slide summarizes the key areas for the updating of the hepatitis B guidelines. This includes the who to treat, the expanding the criteria for treatment with lowering that APRI score from the current level of 2 and lowering the Hep B DNA threshold to 2,000 IU per mil, but also considering other strategies for simplification, also re-looking at the issues of treatment of adolescents and children, looking at the role of TAF and dual therapy versus the current recommendations for tenofovir and entecavir, and the issue of the antiviral prophylaxis recommendation, which at the moment is constrained by those just fulfilling and being able to access the Hep B DNA and having a level above 200,000, but clearly major problems with being able to implement that recommendation with the lack of access to Hep B DNA. And then on the simplifying the diagnosis, just as we did for hepatitis C, looking at the additional role of point of care Hep B DNA alongside laboratory viral load, reflex viral load, that's automatic viral load testing when there's a Hep B surface antigen result. And including Delta testing. And then as for the hepatitis C guidelines, looking at the decentralization, integration, and task shifting. Next slide. And just to clarify the WHO process for guidelines, it is a very formal process. It's a very comprehensive process, starting with a question, commissioning of reviews, systematic reviews of the evidence, but also an overall evaluation of the benefits and harms for a particular intervention or range of interventions, looking at resource use, cost effectiveness, community and healthcare worker acceptability, values and preferences, and feasibility. And where needed, the use of modeling to assess impact. And then with the collation of this evidence base and other information, the formulation of the recommendations. Next slide. So what are the key opportunities as we move forward? Well, the access to the low-cost tenofovir, which is widely available, although with widely varying costs, is a major advantage in the context of hepatitis B that we initially didn't have with hepatitis C. And I think we have some key global initiatives. We've got the new elimination guidance for countries, which very clearly lays out the criteria, both the incidence, that's the hepatitis B surface antigen prevalence in less than 5-year-olds of 0.1%, the mortality target of 4 per 100,000, as well as the service delivery coverage, both of vaccination and testing and treatment. We have now a new integrated strategy for HIV, hepatitis, and STI, which highlights the opportunities for integration, the universal health coverage, the person-centered care, and where primary care is center stage in the scaling up of testing and treatment. And then I think the important opportunity now with the Global Fund, which is expanding the opportunities to support hepatitis B testing alongside HIV and syphilis as part of triple elimination, as well as more flexibility now for including hepatitis testing and treatment in the context of harm reduction and in other settings. And then the opportunities for the decentralization and integration. Next slide. So I think this just highlights some of the critical steps on the simplification pathway. And next slide. And also the evolving opportunities for hepatitis B integration. What do we mean by integration? This can be in the context of both integrating with other testing services or opportunities, such as HIV clinic, antenatal clinics, the opportunities with the diagnostics integrated, as we mentioned a few times, combo serology testing, and the use of existing lab-based as well as point-of-care platforms that have expanded considerably during COVID for molecular diagnosis. And then in the context of service delivery, opportunities for hepatitis B care to be integrated into primary care, and some very promising data emerging on really the delivery of hepatitis B care using the HIV infrastructure, both clinic, pharmacy, and lab for the delivery of hepatitis B care. We've been doing work in Uganda, but there's also other African countries that are now providing data to support the feasibility of this approach. And then very exciting with the opportunities for integrated triple elimination testing, as well as the care pathway with from a study going on in Gambia and Burkina Faso to demonstrate this. And then finally, just the challenges. Next slide. The recognition there is a much more limited evidence base to support our recommendations compared to hepatitis C, the recognition that many of the existing biomarkers do not fully correlate with the molecular immunological status of disease, that a significant proportion of hep B surface antigen positive persons show minimal disease progression over an extended period, and that are not yet fulfilling criteria for indications for treatment for their own health. And then the lack of public sector programs and domestic funding and national insurance schemes that include hepatitis B. So just to acknowledge many colleagues, and thanks, and happy to answer questions.
Philippa, thank you so much for this presentation. Just really valuable to sort of reflect back on the history of where we've come from on hepatitis testing and treatment, and really appreciate the efforts of the WHO and those involved in the guidelines update process to really discuss, evaluate the key questions around the guidelines updates and navigate the challenges to develop evidence-based recommendations. And as you very nicely laid out, lots of key opportunities have emerged to increase access to HPV testing and treatment. Everyone, we've come to the end of our presentations, and I recognize we're very close to the formal end timing of this webinar, but we've received so many interesting and valuable questions that we'd like to at least address a few of them. So if you have the flexibility in your schedules, we will keep the webinar going for a little bit over time, perhaps 10 minutes over time, so that we could address some of the Q&A. With that, I'm going to hand it over to Dr. Emi Okamoto, who's the Associate Director on our Global Diagnostics team, leading support to our HIV and hepatitis teams, who's going to help facilitate the question and answer and discussion session. Emi, over to you.
Great, thank you, Oriel. And again, thank you to all the speakers. Those were excellent presentations to see the available testing and treatment commodities that we can use to close these large gaps, and importantly, how countries are leveraging these for their context. And thank you all for the number of questions coming in. It's fantastic to see the interest and engagement. So let's get into answering some of these live, and we will continue to address those that we cannot answer live in the chat. And for those panelists who are able, we'd love to see you on video, recognizing some of the limitations. First, to Dr. Kabra, we had some questions coming in around the India context, with attendee noting impressive presentation by Dr. Kabra. The first question is, the model used by India was an integration model as described with existing programs. So how do you ensure that the HBV mono-infected patients receive the tenofovir? And the second question is, how do you control the TDF pilferage from the treatment center?
Okay, thank you for the question. I think my presentation was a little not appropriately perceived, because there is a piece that the program offers, which is the diagnostics and management, and we integrate for various components with the other programs. So for mono or dual or any type of infection, there is a treatment site available. As I said, there are 868 treatment sites. They are independently available across the country to offer treatment services. And I also talked about using the logistic and supply chain management systems of the country and the health systems. So we have designated stores, we have designated sites where these drugs are stored, and by routine procedures that we follow for all our commodities and drugs in the country, we dispense the drugs similarly through the available store facilities in the healthcare setups. Thank you. So we avoid pilferage like that. You know, there is no question of pilferage when you use the systems, because all the commodities are looked after in the same mechanism in the health systems. Thank you.
Great. Thank you, Dr. Kabra. And the next question to Asmamal from Ethiopia, around the challenges with resource limitations. There were two. The first being, there's a challenge with Ethiopia having high poverty levels and people having to pay for hepatitis services, which may reduce the number of people screened and treated. And how is Ethiopia addressing this? And I'll add the second one as a follow-on to thinking about resources. Given the difficulty to get HBV viral load, how do you choose who to treat among those who test positive for hepatitis B surface antigen?
Yeah, thank you so much again for the questions. Regarding the burden of the out-of-pocket payments on the patients, yes, it is clear that it's going to be burden for the clients, but the country is trying to make the commodities, for example, TDF, available at cheaper price as much as possible by utilizing the RDF mechanism. And the RDF mechanism, the revolving drug fund mechanism, is found helpful, you know, in managing the price affordable. It will be, I think, addressed as a separate question, but it is found to be very helpful. That is one. The second is the country is implementing a health insurance system, and these viral hepatitis B service are tried to be covered by the existing government-supported public health insurance system, so that is expected to help the patients and avoid the burden on them. Actually, these systems are under development, and yet they are not at perfect level, but they are expected to ease the burdens. Coming to the viral load test availability, yes, it is really a burning issue in the country. After getting people screened positive for hepatitis B surface antigen, then the next step coming or being faced by the patients and also by the healthcare system as a whole is difficulty of accessing viral tests for those who are reactive to hepatitis B surface antigen. So the for the time being, the country is just trying to work to establish network of facilities and the existing laboratories. They are very limited settings with viral load machines for hepatitis B. So there are networks. So samples are sent to those lab centers and then confirmed, and based on those results, treatments can be initiated. Apart from that, there are private facilities augmenting the existing public system. Currently, that is how it is being managed, but it doesn't mean that it is not a problem. It is a problem. The government, the Ministry of Health is working, focusing on this. Yeah.
Great. Thank you, Asmama. And relatedly on the revolving drug fund, which you just spoke about, I want to pose a question to our colleague Ritaban from our global markets team. There were two questions that came in around if you could explain more around how this revolving drug fund system works and what is needed to make it a success.
Thanks, Amy. So I think at the outset, let me clarify that revolving drug funds are not very simple to set up. Setting up prices under revolving drug fund can be complex, and a lot of coordination is needed, as well as there has to be a lot of political will required to actually implement revolving drug fund. But having said that, I think a lot of countries have established revolving drug fund for essential medicines already, and they're also phasing in or piloting revolving drug funds for hepatitis commodities such as TDF. Now, for example, in Ethiopia, under revolving drug fund, demand from hospitals is first aggregated to forecast the need. And then the Central Procurement Division, which is EPSS, purchases TDF, and EPSS does its own process of doing a tender in terms of international competitive bidding and selecting a supplier. So basically it centralizes all the requirements and then does one particular order to the supplier. And in this way is able to achieve a lower price. Subsequently, hospitals then procure TDF from EPSS, which in turn replenishes the fund that EPSS in the first place had used to procure TDF. So in that way, the fund is being revolved, and that's how the system is working in Ethiopia. Back to you, Amy.
Thank you, Ritaban. And Chukwumeka, I wanted to raise a question that was brought up during the registration. This is a very broad one, though maybe we can hear quickly. I think we're interested to hear where are we with hepatitis B programming and implementation in Nigeria.
Thanks, Amy. Can you hear me? Great. So, yes, that's a very thought-provoking question and an interesting one. So, for we in Nigeria, just as Oriel captured on the slide, I think was earlier, for the Nigeria program, it's slightly out-of-pocket driven. So, at the facilities, we have situations where patients are accessing out-of-pocket payments, and the fragmented approach makes it come at high prices. But the opportunities for us to think of, having the pool procurement mechanisms, and the good thing that we have now is with the global fund opportunity coming in, it could be an avenue to start to think about strengthening the hepatitis B program in Nigeria, and also to see how we could improve access to these services in the country. But as we stand, the fragmented processes and systems in place makes the cost really high, and also difficult to access these services. But I think with this report, we've seen opportunities to work collaboratively with the government and also with the pharmaceutical counterparts to market shape around these prices. And as we look forward to leveraging and integrating into the global fund opportunities overall.
Great, thank you, Chukwumeka. And our next question I wanted to pass to Philippa of the WHO. So Dr. Philippa, if you could update us on some timing of the upcoming HBV guidelines updates, and also particularly around the diagnostic hepatitis B antigen. As we saw, there are a few products on the market. However, there's no WHO pre-qualification process, which makes it challenging for some countries to procure this. I believe we had a question coming in from Cambodia. So if you could speak to this, and if there is a chance for hepatitis E antigen to go through a WHO pre-qualification process. Thank you.
Thank you very much. So I think the question on the date, so the plan is for the guidelines meeting to be early May, and then with dissemination from July onwards of the recommendations. In terms of the diagnostics, the hepatitis B DNA and both the lab-based and the point of care are now out for a call for submissions. This has been quite a long process because I think the focus on COVID did result in a delay in the pre-qualification process for other diseases. So I think I'm hopeful that this will now move swiftly. In terms of e-antigen, I think I recognize that is very important. And I think this should be a priority for advocacy to really ensure that this is taken forward. I think there have been discussions with pre-qualification. They're aware this should be follow suit as for the Hep B DNA, lab-based and point of care. And I'm hopeful that this also is something that can be activated in 2023. But I think it'll be good to have some further dialogue about this, about a group that can really help advocate to drive this forward in 2023. Thank you.
Great, thank you, Dr. Philippa. And I see a few other questions coming in. We may try and respond to these via email and reach out. Really appreciate all the engagement here and the time able to spend elaborating on this. Given the time, let me pass it back to you, Oriel.
Thanks so much, Emmy, and thanks for all of the questions and to those who responded to the questions. We're over time, so I'll make these closing remarks really, really brief. Firstly, I just want to say a big thank you to all of our presenters who really took the time out of their schedules to prepare their presentations and share both country and global experiences with us. A big thank you to all of you who joined this webinar and made time to stay a bit over. Hopefully some of the take-home messages you're leaving this webinar with is that we have an incredible amount of opportunities now to increase access to hepatitis B testing and treatment. And these range from expected policy shifts that Philippa talked to financing opportunities with agents like the Global Fund. And we have examples of countries who are able now to access HBV commodities at affordable rates and increase uptake of HBV care. So this is really an opportune time for more countries to build upon this momentum and start to expand testing and treatment. But as we're building our programs, some of the points Kenneth mentioned, the need for community engagement in this process, the need to build awareness and think about all of the demand side barriers are going to be really, really critical. Just again, we'll be sharing the presentations in addition to the responses to the questions we didn't get to. Lastly, as I said, this market report is part of a series of market intelligence that CHAI periodically releases. So we're just in the process of working on the third edition of our hepatitis C market report and hope to publish that in Q4 this year. So look out for that later this year. And thanks once again, everyone, for joining us, and have a good rest of your days or evenings.
Thank you.